Yes,
So good
sir,
morning. Yeah, thank you.
Yes, sir, we are live now.
Thank you, Marshi. So good morning, everyone. And today we are doing a quick audit of trauma cases which came to us for in last 1.5 months. We have selected some cases which can give message for all the treating all the pediatric orthopedicians. So the format is current fellows would present those cases in a prescribed format. We have panelists, Dr. Gaurav, Vikas is there, and Chinmay, who are our ex-alumni. And then we have external experts. Thomas is there. Deepak is there. Sandeep Patwardhan is going to join. So we will ask to them that what they would have done in this situation. So let's start. Meet and Goda, please start presenting, and then we'll take the discussion.
Yes.
Welcome, Akanksha Jayasinghe. Dr. Jayasinghe. Good morning. Dr. Jayasinghe is from Sri Lanka. Yeah.
Good morning.
Yes, Goda, please start.
Good morning, everyone. So the first case is like we had a 6.5-year-old girl who presented with history of fall over the left elbow while skating, and on examination there was swelling and tenderness over the left elbow, more so on the medial aspect. There were no distal neurovascular deficits, and the radiograph is this. We got a AP and a lateral view of the elbow, and it showed a
Okay, so Goda, let's stop here. And Gaurav, would you read this X-ray?
Yes, sir. So, so I feel so there is a fracture of the medial epicondyle. It's a displaced fracture, and apart from that, other aspects look normal to me. It's yeah.
Right. So Vikas, now, do you think this needs management? The distance we measured on X-ray is about 4.5 millimeters.
Yes.
What literature says? Can we conserve it or we should fix it? There's a non-dominant hand.
So the fracture fragment appears to be rotated, so we need to fix it.
That's right. So how could you judge that it is rotated?
So the metaphyseal fragment is appearing lateral to.
That's right. So Qaisur, would you like to do something to confirm that this is a rotated fragment, or you believe it is rotated?
We can always ask for a CT, 3D CT scan to confirm it, but
Okay.
I would say it's rotated. Most of the time, lateral condyle fracture, after fracture, the fragment is so far behind, most of the time it's rotated.
Sir, an opposite side elbow is the least we can do.
This is extremely good point. So we always take contralateral X-ray and see whether it's rotated or just displaced. The current treatment indication is more than 5 millimeter displacement and a dominant hand. A paper from Ippolito, if there's a very nice paper, and they have a series of conservatively treated medial epicondyle. If you have time, you can go through, and they have treated all medial epicondyles conservatively without any resultant instabilities. So Deepak, I agree with you that in contralateral X-ray, Chinmay is of opinion to fix it. Yeah,
Sir, can I add something, sir?
Yes, please.
So just like a Shenton line in neck femur, we can also trace the metaphysis line, and we can go up to the medial epicondyle. If it is not in a one line, we can say that it's a fracture of medial epicondyle.
Yeah.
And similarly,
that's an early sign. That's right. But
yes,
we should have X-ray of both the sides to comment on that, right? Yes. Let's see what we have done, Goda.
So this was a non-dominant hand and a less than 5 mm displacement. So we went ahead and got a contralateral side X-ray radiograph. So this on the left is of the contralateral side, on the right is of the fracture side. So we got to know, we got to know that the fragment was rotated.
Right. So that's this a comparison view is always right. Now, Deepak, how would you treat it? How would you fix it?
Sir, I've also read that article which you were suggesting most of these cases can be managed conservatively whenever there is no incarceration of the fragment into joint or no ulnar nerve involvement. So in my hand, I will manage this case conservatively.
Okay. Yes, Gaurav, how would you treat it?
Sir, I would like to get an MRI to see, because sometimes on X-rays we can't assess the exact displacement and rotation. Although on X-ray it looks quite displaced and rotated. So I would like to get an MRI and assess. And yes, as we say that if it is, as Dr. Deepak has told, that if it is not intra-articular or if there are not no ulnar nerve symptoms, then we can conserve it. So my inclination would be to conserve.
Okay. When it comes to this webinar, everyone starts conserving, huh? Anyways, so let's see what Vikas has to say. Vikas?
Yeah, I think we can go for fixation, because recently I've seen a similar fracture. It was a pretty old fracture with a tardy ulnar nerve palsy.
Yeah, so that is an instability, and progressive valgus can lead to that. Thomas is with us. Thomas, how would you manage this?
Yeah, like you said, getting the contralateral X-ray is important. The size of the fragment and the displacement. And I'm just wondering whether a good ultrasonologist will be able to tell whether it's rotated and the articular surface is pointing the other way.
Right.
Those factors will determine my whether and it being non-dominant, I might be tempted to leave it untreated if it's not too far from the.
Yeah, actually, no, this is a 180-degree flipped fragment. I will show you the intra pictures. Yes, Gaurav, what do you want to say?
So I want to say that I would also like to assess the stability, if I can. I mean,
see, in young children, you know, when you try to move it, they are really cranky.
Yeah,
so you don't know whether it is they are guarding it or it's a real instability. But you will see. Godha, please show. Move ahead and.
Yes, sir. So the classification.
Yeah, Qaisur, your comment.
So I would like to transposition the ulnar nerve and then fix it with a K-wire. I think that would be a good idea, because in the long run that may cause some tardy ulnar nerve per se. Other than that, cosmetic effect is there also. Cosmesis,
so
like
transposition is indicated in cases with tardy ulnar nerve palsy if they develop in future. There are incidents when the patient has significant cubitus valgus and tardy ulnar nerve palsy. The valgus is not hampering them, and then you just do the transposition. But to do in an acute case will be a bit overkill. Let's see what we have done. Yeah, Godha, go ahead.
Yes, sir. So the medial condyle, like here we can see the ulnar nerve, we explored and isolated it. The medial condyle was 180-degree rotated, and we flipped it back to its original position and later fixed it with a CC screw.
Yeah, so can you go back to the previous slide? So you can see that the fragment, you can see the metaphysis when you open, once you drain the hematoma. So always a principle, medial epicondyle, you open it and fix it. And lateral condyle, if it is reducible and you do an arthrogram, you can manage it by closed means. But medial epicondyle, always open, because you see this ulnar nerve is lying just behind it, and you have to retract it and then to put this fragment. So it's difficult to understand that this would heal in this way, which is bit distal and anterior, and the flexors would keep on pulling them. So once we opened it, we realized that it's better to fix it this way. Yeah, go ahead. And the retraction of ulnar nerve is very important.
So this is post-fixation with CC screw, and the immediate post-op radiographs shows good reduction. And this is 1 month post-surgery.
So we started range of motion at a month, and 4 mm CC would do the job. Now, if the fragment is too small, then you can use K wires. Okay, you bend it in front and then remove it after a month. But here, what you see is a just bony part. So cartilaginous part is bigger than this. So we place the screw.
So
right.
what is your cutoff regarding the displacement? Because actual displacement, which is we can see on X-ray, is way much on CT.
Yeah. So what we see on X-ray is not a neutral view. So it's a rotated view. The medial epicondyle lies little posterior. So people have recommended that you do a CT scan. But on X-ray, this was looking displaced and it was flipped and reversed. So I think we should fix this, because this may go into non-union and pain, because it is not the metaphysis, not facing the metaphysis. It was the epiphysis which was facing. So any flipped medial epicondyle with displacement more than 5 mm should be fixed, regardless it is dominant or non-dominant.
But there are some literature reporting even the non-union are asymptomatic in case of medial epicondyle.
No, but see, if 1 out of 5 becomes painful, no, then it's a problem. And what happens? It goes distally. Then it goes distally, and then it becomes very difficult to fix. And this is a very straightforward surgery. So non-unions, where the fragment has not been displaced, not been flipped, then you can leave it. Medial epicondyle, not medial condyle, as mentioned the classification slide. Yes, that's right. Yes, Chinmay?
Sir, hello. We add one more view in this, sir. So there is one is axial view for the distal humerus, which can show the actual displacement and the rotation also. This was a paper coming from Dr. Edmonds, I think.
Okay.
So they show, rather than going for the
axial view, how they take axial view?
So 45-degree obliques. I can share the paper in our group. So they come up with a comparison with normal X-ray, CT scan, and the axial view.
So that is in external oblique view?
No, sir. Axial view is like what we take for shoulder, that they similarly took for the distal.
Okay. So yeah, you share that paper. That will be of great help.
Yes, sir. Sure.
What if it is 1 month old? Should we open or leave it, Dr. Sharad? 1 month old, then I will look for the signs of instability, pain. If it is child doesn't have pain, then you can leave it. If there is no instability, then you can leave it. If it is unstable, painful, then you go open and fix it. Sometimes you are not able to fix at its native place. You might have to fix a little distal, Yeah, let's move on to the next case. And those participants who are not, talking, can mute yourself, because we listen, have a lot of background noise. If it is, this fragment is too small, you can always fix with a wire or a suture anchor. Gaurav. Yes, Goda. Let's take next case.
So here we have a 6-year-old boy. He had a history of polytrauma. He had a road traffic accident, and he had chest trauma and abdominal trauma along with it. He had a hemoperitoneum with splenic laceration, bilateral pleural effusion, and he presented to us with this X-ray.
Yes. So, Vikas, would you read this X-ray? What do you find abnormal here?
So there's a fracture of the subprognatic area. Along with it, there is a dislocation of hip joint.
Yes, that's right.
Acetabulum appears now.
Yeah, so pelvis looks okay. Gaurav, you want to add anything to that?
So something strange is that there is a dislocation. Along with that, there is a proximal fracture, which is highly uncommon. Either we see fracture or we see dislocation. So that is strange for me.
Yeah, so Meet found that there are only 3 cases reported in world literature so far. So there is combination also, there is an a child was so sick, we could not take other views. So yeah, that's right, Qaisur. So the Thomas is here. Thomas, how would you manage this polytrauma case? What should be the priority of management?
Yeah, so obviously the chest trauma and the abdominal trauma should be looked into first. All the ABCs of resuscitation. Make sure hemodynamically the patient is stable. Abdomen is fine. Splint.
So it took about 6 days for child to become hemodynamically stable. Pediatric surgical team decided to treat all these splenic and liver lacerations conservatively. The pleural effusion part required probably an ICD insertion, but that also got managed. Now at 6 days, we have this situation. So how you would go for it,
The hip dislocation part, whether there's a articular fragment or not, I think some more imaging is required, I think.
Okay.
So whether a CT or a MR, if possible.
So a CT scan to see whether there is any, or an MRI to see whether there is any head fragment or acetabular fragment.
Yeah.
With the dislocation is there. That's right. I looked at the X-ray and compared the acetabulum, that looked okay, and I didn't think of the head, but I agree with you that further imaging could have helped. Now,
osteochondral fragment.
Now let's assume that MRI shows that there is no osteochondral fragment. This is an isolated injury. Then how would you manage this? So
I think that this dislocation may, this is tricky. I'm just wondering whether.
So this dilemma, we also had whether to
do the hip first or the shaft first.
Reduce the hip first or the femur first.
Yeah.
Can we reduce the hip? Yeah. So Meet, take us through the dilemma, and then we'll inquire with all. Yeah. So
this was the dilemma, that should we reduce the hip first or the shaft, and if the hip, then how do we reduce it? Should we just try for a simple traction, just try and pull the head back into the acetabulum, or should we use a shank spin in the neck and then try to reduce it? And if we plan to do reduce the shaft femur first, which was what was done in the literature that has been reported, so should we use a TENS to fix it, a temporary external fixator, or should we open and plate it, give a rigid fixation, and then give a traction to reduce the hip?
Yeah. So this was the dilemma. The literature says that they fixed the femur fragment first, and then it made a one unit, and then they pulled on the hip. So Gaurav, how would you go for it? Meet, can you go back to the X-ray?
I would first try to joystick the head inside. I'll try to reduce the head inside. If I am able to do it easily, then I will then proceed with fixation of the shaft. But if not, then I would first try to, then I would fix the shaft, make it a unit, and then reduce it.
Right. Yes, Vikas, what do you think? How this will get in?
In any case, I would have preferred to go with reduction of the head first, either closed by the assisted method, or if it is required, then an open method. But the literature which says in these acute settings, whenever the dislocation anteriorly, we should approach anteriorly. When the dislocation is posteriorly, we should approach posteriorly. So it all depends on the position of the dislocation.
Yeah, so you wanted to fix, reduce the hip first, and then
fix it.
Okay. Yes, Vikas, do you have any other thoughts, or you think on the same line?
Yes, I think on the same line. I would have gone for the same thing. If I can reduce the head by close means, so we can do that.
Yeah, so literature shows that they want to make the femur one unit and then try to pull it. But so we had all this dilemma, and then I thought, let's just give the traction first and see what happens. You know, if hip doesn't reduce, then and femur aligns, then we'll fix femur and then pull this as a same segment. I also thought that if hip is not coming, then I might put a temporary external fixator and then pull that on that fixator gently under complete relaxation. So with all these ideas, we went in, and all dilemmas and confusions. Meet, show what we have done.
Sir, what was your approach or thought if the close reduction was not possible? Like, if you will be needing open reduction, then what will be your approach?
So close reduction, if it is not possible, my first thought was I will put an external fixator. I kept the LRS ready. I'll put one shan't spin the proximal and distal fragment fixed with an LRS, and then pull on the fixator. That was my first thought. And let's see what happened.
So we tried to gently reduce the head and put it back into the acetabulum, and that worked well, and the hip was reduced. So we managed close reduction for the hip.
So this happens, you know, like you give full relaxation and pull it. So we know that the bones are not joined, but the soft tissue is there, which is soft tissue is not broken. So a stretch on soft tissue, and then the head came on the margin, and with just gentle pressure from the posterior side, it jumped in. And once it jumped in, it was difficult to redislocate it, you know. So it was a stable reduction, but still we fix it with a temporary wire. And Meet, show further.
So we transfixed this temporarily to the acetabulum with a wire, and after that we went.
And then go back to that slide. So when I did this, I was very happy looking at the AP view. Now it'll be very easy to fix the femur with TENS. But when I looked at the lateral view, the proximal fragment was in significant flexion. So, Vikas, what do you think? This was remaining in flexion because this probably iliopsoas or something is pulling it up. It was not coming down.
So we can wait and for that. So fixation of shaft femur, we can stretch it out slowly.
अरे लेकिन reduce ही नहीं हो रहा था भाई.
नहीं sir, head was reduced. Head तो reduce हो गया.
Head reduce हो गया. Shaft femur was not reducing.
Okay, so then we need to pull that pin out again.
We did that. We pulled the pin out, but still the fragment was remaining in flexion.
Okay.
So yeah, that's what we did, Gaurav. We opened the fracture. I mean, we tried a lot, but we could not reduce it by close means. I think we passed the TENS from the distal fragment, and then also manipulated that if we can achieve reduction, if we can maneuver one nail through, but it was not going through. So we had to open at the last as a last resort and show Meet what happened. So this is how we could pass. Yeah.
We got close reduction for the hip, but for the shaft femur, which we thought would reduce in the closed manner, turned out to be a more difficult challenge. So this is the follow-up that we have at 1 month.
So now it's about 1.5 months, and child is now walking. Fortunately, he has improved on all his surgical site, you know, pleural effusion, hip, liver, spleen, everything has healed well without any surgery. Just an ICD was removed before child was discharged. And femur, now child has started weight bearing with walker. We can try pushing the proximal fragment with an artery for, this was not possible. When I opened, you know, there was some muscles lying in between. And even after taking those muscles off, you know, it was very difficult to reduce it. why people with head injury throw exuberant callus. I think Thomas, sorry, micromotion?
Micromotion, and also some says there's some factor releasing from the brain.
Yeah,
injury causing.
That's right. Thomas, do you have idea why there is exuberant callus in head injury patients?
Yeah, they say there's some factor is released, some neurotrophic factor. I think they characterized it some recently. I'm not sure what exactly. I've forgotten the factor, which is from the hippocampus, I think.
So this child did not have head injury, but this is my struggle during reduction that shows in the form of periosteal elevation and callus. This is all pure iatrogenic.
Post-op spica?
Yeah. We applied spica, I think 1.5 spica for about a month, with pediatric surgeons being around so that this abdomen can be observed. So we applied spica. Yeah. Okay. So let's move on to the next case. Any comment by the time Gouda starts another one?
I have a similar case, but that was 6 months neglected. So it had a deformity at the femur and the head was dislocated posteriorly. Acetabulum was okay. So I am I've given that case for polytrauma part. So maybe if they select, then I'll present there.
Sorry, what did you do? You went on posterior approach?
No, sir, anterior approach, because it was 6 months old. So literature, there is no consensus for the approach in that late stage. And since to start with, the dislocation was slight subluxation, but the child started walking and the primary surgeon left it untreated, the head. And with time, because of the weight bearing, it dislocated much superiorly.
Yeah, that's
so
a more challenging situation it is, yes. Sujit is asking, any attempt to remove the intramedullary fragment? No, Sujit, we don't remove it. It kind of heals and remodels. Reduction of hip versus reduction of fracture first, how does it matter? Gaurav, people think that a real dislocation of hip needs a proper lever arm to reduce it, and so the femur, if femur is intact, we can reduce it well. That's what everyone thinks.
Maulin, yes, that's a nice just a comment.
Yeah.
I think nicely managed, but I would have been tempted to use a submuscular plate, a small plate for a subtrochanteric fracture rather than a tense nail.
Yeah. See, I already passed the tense, thinking that this for subtroch a little proximal metaphyseal, we have been doing enders for UBCs and all. So yeah, we were okay with it, but we have already passed the tense. We have all inventory ready, but that can be done. I agree with you.
Okay.
Gouda, please take us through third case.
So the next case, a 7-year-old girl. A 7-year-old girl presented to us 2 days after a fall on an outstretched hand. She complained of pain and swelling in the left wrist and forearm. She was given a plaster slab elsewhere and she presented us in this way. There was swelling, deformity, capitis and abnormal mobility in the lower wrist and distal forearm. So the radiographs, the AP and the lateral view, these were taken elsewhere and they showed distal and radius fracture, both bone forearm fracture. So is it a Galleazzi variant, and how will we manage this fracture?
Yeah, let's go back to X-ray. Qaisur, what do you think?
Yes, sir. Looks like it's a Galleazzi variant. And how many days passed after trauma?
2 days, sir.
2 days. I think we can try close reduction once again. Radius has intact periosteum and there is some bowing. I think close reduction can be tried.
Right. Yeah. So Gaurav, what do you think about this?
Yes, sir. It is a Galleazzi variant, as there is distal third fracture of radius with dislocation of distal radioulnar joint, and fracture of the ulna. So yes, first attempt would be close reduction. If it will, yeah.
Yeah, Vikas, do you have any other thoughts? Chinmay, or for anyone, like any.
Intact ulna, generally they dislocate. Do you want to go posteriorly with intact ulna? Whenever there is an ulna fracture along with radius fracture, is very unlikely to have DORG dislocation. And this X-ray is also not true lateral.
Yeah, that's right. So the first thing is we should have an ideal view, or we should have a comparison view, that is it a real Galleazzi's or just the distal radius ulnar fracture, you know. So Godha, show the further how we did.
So we got comparative X-rays of the contralateral site, AP and lateral. And
so one can see that a bit of dorsal. This is an oblique view, and the distal ulna is bit dorsal, the ossified part of metaphysis, you know, and the distal radioulnar relation is not much disturbed. So it doesn't look like a typical Galleazzi's fracture, but maybe a bit of variant kind of thing. So show Godha what we did. Yeah.
Whenever there is an ulnar fracture, it is highly unlikely to have a divergent dislocation along with the radius fracture.
Yeah, so there is a variant described, Deepak. Yes, it's just like in Montage, there's Galleazzi's variant. You can look into it. But I agree that now we see dislocations with fractures. You know, you saw the Shah femur.
Yes, sir.
Anyways, so that's right. But Godha, show what we did.
So we attempted a closed reduction under relaxation under general anesthesia, and this is immediate post-reduction radiograph.
So would you accept this, Gaurav, Deepak, Vikas, or you would do something else?
Sir, do you intraoperatively break the radius to correct the alignment, or you just?
We gave traction, and you know, while doing maneuver, we felt a crack. So the unicortical might have converted bicortical fracture, but the ulna was a bit bayonet. Qaisur says you accept it.
Sir, as I have taken the child in OT and I am doing it under anesthesia, I would like to reduce it.
Okay, you want to align it 100%? We
100%,
also felt a pop, you know, so the ulna also set at its place. Now, if you compare the AP with then normal side AP, it's like it looks normal. You see this, the X-ray on your left. So I accepted it, you know, then it will remodel. The young child, 6-7 years old. So I accepted it. Yeah, Godha, show the next X-ray.
This is the acceptability criteria for age less than 10 years, and 1 centimeter bayoneting over here is acceptable.
Yeah.
So our take-home message is contralateral radiograph can help in defining the fracture pattern.
Right. Did we have any further follow-up on this, Godha?
Recently done, just about 10 days back.
It's not. It's here.
We don't have a follow-up radiograph yet.
Okay, fine.
So
Okay, let's move.
So the distal radioulnar joint was reduced.
Yeah, that's what. The distal radioulnar joint was well aligned, and radius looked okay. There was bayonet in ulna, and I am hopeful that this will remodel. So I'll update you guys what we conserved, and child is I think 3 weeks out. Follow-up X-ray showing healing of both radius and ulna. We'll keep it on for further 10 days and remove it. Yes, let's go on to the next case. this case just shows that an contralateral X-ray is important. That's yeah. Next case.
Yes, sir. So the fourth case. So we have a 10-year-old girl. She presented to us with a history of twisting injury of the ankle while getting up from the school bench. This happened 12 hours ago, and she came to us with mild swelling and tenderness of the right ankle. So we had the X-rays done, both the AP and the lateral views.
So let Vikas or Qaisur, can you comment what is this?
So
What sort of?
It's called triplane fracture.
There
is a metaphyseal fragment with a epiphyseal slip.
That's right. Right. So how would you manage this, Vikas, or what further studies you would like to do it?
You can get a CT to confirm it.
That's right. Yeah. So I think Qaisur have made the lines. Qaisur, can you remove these blue lines if you can?
Sir, the host can remove those lines. Sorry, sir.
That's okay, but kaise remove karne ka?
Someone using the phone just
opening the whiteboard will start.
Reshare the presentation, sir. Take a minute.
No, हो गया, एक तो निकल गया भाई.
तो उसके ऊपर क्लिक करना है सिर्फ.
अच्छा, okay, let me do this. मेरे से तो नहीं हो रहा है. Anyways, चलो. Anyways, no problem. Let's move ahead.
So we got the CT scan done.
Yeah.
And these are the 3 views that we have.
Okay. So Vikas, would you read this CT scan now?
So it's a triplane fracture. Along with it, there is a medial medullaris fracture also. Is there?
Yeah.
So
there's
a
a medial
type 4 epiphyseal injury. Shorter arrest type 4.
So is it, we had a discussion between Meet and Godha. Is it a 3-part or a 2-part or a 4-part triplane? It's a triplane fracture because we see it in all the 3 planes. But is it a 2-part or a 3-part? How would you define it? And how it would, would change the management. So what I always try to teach is you get a CT scan. CT scan is must. And then you make your decisions of trajectory of your screws based on the axial cuts. So if you see there is bottom axial cut on the most lateral side, on the most left side, you see, can you see my arrow by any chance or not?
No, sir.
No, okay, fine. So Meet, can you show the most lateral? So most left is a metaphysis, and as you go distal, 1, 2, 3, 4, 5. So the 6th image, that is a cartilage. Do see more whitish and grayish? That is the growth plate. And then you go further down, it's an epicondyle. So it's a medial epicondyle. So you can see there's a saltaris type 4. This is but fragment in the metaphysis, which is posteromedial, while the medial malleolus part is posteromedial, posterolateral. So your screw trajectory should be Meet. You have marked that?
Yes, sir.
Yeah. So we planned that the epiphyseal screw should be going from anteromedial to posterolateral like this. So that will catch the fragment, and the metaphyseal fragment we will grow from front to back. Do you have another image, Meet?
So for the screws,
so this is actually the metaphyseal image. Go back. Okay, so The epiphyseal, we have to go from anteromedial to posterolateral, okay, and not pure horizontal, because if you pass a pure horizontal from the center, then you would not have a good hold of the posterior part of the epiphysis. And the other which Meet show was the metaphyseal trajectory. Yeah, go ahead, Meet. So this metaphyseal trajectory, we should be more anteromedial. Yeah, I wanted to display other image, Meet, actually, not this coronal image. Anyways, let's go ahead and show what we have done.
So, what would the possible plans we should? Can
we conserve it? The first question is, can we conserve it? Anyone? So Sudhanshu is here. Sudhanshu, would you conserve it?
Good morning, sir. No, sir, I won't conserve it. I'll fix it with the
Why?
screws. Because intra-articular component is there. Intra-articular fracture has to be reduced perfectly and compressed.
Yeah. So many a times, we see triplane where minimally displaced, where intra-articular displacement is less than 2 millimeters. In those cases, when you do CT scan, if it's an inversion injury or eversion injury, then you invert the foot, apply a slab or and send patient for a CT scan, so that you can see that in this position of the limb, the fracture reduces 100% or not. And at times you will see it reduces fully and you can conserve. But in this was a fairly displaced, and if you conserve, sometimes it get further displaced and may cause arthritic risk in the future. So we must fix it.
Okay.
So, and close reduction and screw fixation is a good idea. Yeah, show what we have done. Yeah.
So this is just a classification of the triplane fracture by parts. So we have 2, 3, and 4. These are based on the number of parts of the fracture. And we have another classification where we have done it where there's a lateral triplane, a medial triplane, and intramallular. So the particular fracture that we had looked more like a medial triplane fracture. And so this is what we did intro.
Now, when we fix this epiphyseal screw, the medial malleolus fracture was looking well aligned. And then we passed a metaphyseal screw. We saw that this metaphyseal spike is still lifted. So the compression was not great. So I was not that happy. But so Deepak or Sudhanshu, do you go from posterior to anterior or anterior to posterior? For
so
such,
whenever it requires an open reduction, though, I prefer posterior to anterior. Sometimes what happens
this was a closed reduction, no? We are not doing
closed reduction. Best method is to go from anterior to posterior.
Yeah. So you are happy with this X-ray?
Yes, sir.
Yeah. So I'm sure this is going to heal well, but it did not give the compression which I was looking at,
So what I feel that when the fracture slips like this, there is an anterior periosteal impingement and get impinged between the physes, epiphyseal and metaphyseal anteriorly. So sometimes that doesn't allow the fracture to get reduced completely.
Okay, yeah. So that's a good idea, that I might have opened it in front and see if periosteum is lying in between.
Yes. So it doesn't allow it. It acts like
but Sudhanshu, when I kind of dorsiflexed the ankle,
okay, sir,
it was looking well aligned.
Okay.
So I don't think there was this thing.
Sir, do you put the screw after doing the opposite maneuver of the fracture? Then at that time it will get reduced and
yeah. That's what we did. For the medial malleolus, we kind of everted the foot, and it was aligned, and then I think I kept the reduction and placed the screw. So that's what we should do. But once we did that, we thought that with the metaphyseal screw will compress the fragment completely, but it did not. But then I thought that it's okay, it will heal. Anyways, let's see, and we'll post what happens. This child is old, and let's see what happens if the growth plates gets injured or not.
So these are the take-home messages that if we have only a single view, we will miss this fracture. And triplane fractures belong to a group of injuries called as transitional injuries, which occur in the age group of 10 to 17. So for ankle fractures in this group, a CT scan would be a wise thing to do so that we don't miss the axial view.
So Gaurav, putting a screw from posterior to anterior, this we might have to open it and go between the tendo-Achilles and the neurovascular structures and retract the muscle. That will be a bit mini open kind of thing. That can be done. Yeah.
Sir, on the post-op X-ray, there was a little anterior opening in the physis.
Yeah, I saw that.
So I think the way you said, if we did a little bit of dorsiflexion, it would close, and then in that same maneuver or dorsiflexion, if you could pass the screw, it would stay. I would suppose.
Yeah. So what I feel is that we could not maintain that maneuver while passing the screw. I don't know whether this much of opening will make a difference. We'll see in future. So. Yes, Kapil. Kapil is here. Kapil, would you do it differently? Are you with us? Kapil is senior orthopod, so he have a lot of experience in it. Anyways, let's move on to a few more cases which are very interesting. Yeah.
So we have an 8-year-old girl.
Yes.
Presented with complaints of pain and swelling in the left wrist and forearm. There was history of fall 12 days back. The parents noticed the deformity 12 days after the injury. And on clinical presentation, there was a dorsal bump and there was limited and painful supination. These are her radiographs showing a Galleazzi fracture, AP and lateral view.
So now, Deepak, do you agree that this is Galleazzi's? Or Gaurav? The radius is fractured and the ulnar, distal radio-ulnar joint looks distracted.
Subluxation of DURG, this is a typical Galleazzi. But sir, what might happen is she might be having some torus fracture or something like that, which further collapsed and then led it to further subluxation of the DURG with time.
Yeah, that's difficult to explain. But somehow, like what mother told us, that child was like kind of hiding the trauma, which she was a bit afraid. And after 1 week, they saw that the dorsal bump is increasing, and that's how they came to us after 12 days. So now this is not a fresh injury, this is 12 days old. So what to do for this 12 days old injury with limited supination?
This will require proper reduction of the radius and reduction of the DURG and fixation.
And fixation. What if this reduction doesn't come because it's 12 days old? Would you do osteoclysis of radius?
Yes, sir. Because without reducing the deformity of the radius, you will not be able to reduce the DURG. And here, the reduction of DURG is more important. The pronation.
Can you just correct the rotation and see what happens in future and come back at later date, or it should be done at this point at 12 days of injury? Can that be an approach?
The rotation will be corrected only when the deformity will be corrected. If deformity is not
so your thought is we have to correct it by any means. If it is not coming, then you osteoclysis, you reduce radius. Yes. Any other thoughts? So this came to my mind.
Getting an elbow.
This Raghavendra is here. Kapil, Sharad, any Sudhanshu? Yeah, sorry, I didn't get it, Deepak. So any other thought?
Elbow X-ray also, just to rule out.
To rule out? To rule out what?
Proximal radial ulnar joint injury.
Okay. Proximal radial ulnar joint was okay. Let's take it that way. Any other comment?
Pronation injury, sir, because our angulation is on the dorsal aspect, so the DRUJ disrupted. So I would like to give a maneuver of supination with the, maneuver and pressure over the angulation, which there is a deformity. So give a trial of close reduction and then see it again.
That's right. Now, we all know that we have to do. The question was, what if it doesn't reduce? Now, sometimes we see plastic deformation, it doesn't reduce, and then
sir, if it doesn't reduce, then we may go dorsally percutaneous open and then put a K-wire and then angulate it.
Yeah. But the key thing is we have to align the radioulnar joint. That is must. Because we just cannot keep on waiting that let it heal, remodel. Because this sort of injuries, it will keep on rotating more. And we have seen some patient with pronation fixed deformities, and then we have to osteotomize them in a later date. Yeah, but we were kind of fortunate in this case. Godha, show what happened.
What type of injury and how do we manage it? So it is a type 2 Walsh classification, volar displacement of radius due to pronation force. And our plan was to give a cast to improve supination and correct the residual deformity later if we would not be able to correct it in relaxation under GA. So, but as we gave traction and counter traction, we were able to reduce the DRUJ disruption and properly, satisfactorily reduce the fracture in this case. So these are the immediate post-operative images showing good reduction. And the lesson we learned from this case is close reduction under adequate relaxation can be successful in late presentation as well.
Yeah, so we felt a nice pop of distal ulnar reduction into druge. And then we did the 3-point pressure. And then as Raghavendra said, then we applied plaster and supination so that we counteracted the rotation, the pronation injury. Yeah.
If sir, one question. Sir, if we have to open it, from which side you will open? I would like to open it from volar side, and because that is compression side. If I just want, because somebody told dorsal side. Any comments on that?
So, I mean, open means it will not require a formal open, but to just do an osteoclysis, whatever callus is, it just osteotomize and then you reduce it. So you are not going to fix it. So dorsal mini thing is okay.
Okay.
Because in volar side you will come across the vessels and also dorsal is okay. Yeah. So we have 10 minutes and we have to go through 3 quick cases. Yes, Meet, shoot.
So we have a 7-year-old boy who had a history of falls from a swing one day back, and he landed on the feet with a supinated left ankle. So on examination, there was tenderness of the medial muscles and swelling over it as well. So as we can see on the X-ray, this is a straightforward assault arrest type 3 injury. And
now, Meet, where is the real X-ray? Now, this is image intensifier image, buddy. Where is the X-ray?
I think I'll just.
Do you have X-ray?
I think, yeah, I have not added to this presentation.
Okay, so X-ray should be placed. Anyways, so this is Gaurav. How would you treat it?
Sir, I would like to close reduce it and fix it percutaneously.
Okay. How to now? You can see this. How would you see that your reduction is okay?
Sir, I would either see on the C-arm if I am able to make out. Otherwise, I can try to do an arthrogram.
Yeah, that's right. The arthrogram is a good adjunct. So, what if you are not able to achieve good reduction, close reduction? then of course you should not hesitate to do
Right.
open reduction, right?
Yeah.
So let's see how it went. Actually, this is more displaced than what it looks here. Yeah, Meet, show what you have done.
So the option that we had was open and anatomically reduce it, or should we go for a closed reduction and internal fixation? So this is what we performed. We first marked the medial mass fragment, and after that we used the joystick maneuver. We passed the KY in the fracture fragment, lifted it up, and we managed to reduce it in a acceptable manner. And after that, to confirm the reduction, as sir mentioned, we performed an arthrogram. Following this, the reduction was acceptable, so we passed a guide wire, and then subsequently we passed a screw and compressed the fracture. So these are the introp images that we had, the final introp images. And this is the post-op X-ray, the immediate post-op X-ray.
Right. So the other, the problem is whether this 4 mm CC will go or not. That's the question. So always what we do is we have a magnification thing, or what you say calibration of your X-ray. So you can measure the exact width or height of epiphysis. So wherever you do X-ray, if you have X-ray at your center or you are getting X-ray at some other center, make sure that calibration is right and your magnification you should be aware. What if the size of epiphysis was a little thinner or smaller, then this screw would be going through the articular cartilage. So if you don't have 4 mm screw, then you can have 3 mm, 3.5 millimeters, whatever screws or Herbert screws of this length should be managed. But we measure that this is about 5 mm size, so our 4 mm CC will go through. Another thing, we always thought that it will need an open reduction, but with this joystick kind of thing, which Meet suggested that let's do a joystick. So that's a very good idea. With a joystick, you pass a temporary wire and you pass your guide wire and then fix it. So there's a good technique to deal with it. Yeah. Okay, Meet, good points. Move ahead.
So the next case, we had a 7.5-year-old boy who was a known case of polyostotic fibrous dysplasia, and he presented to us after a trivial fall with complaints of pain, swelling, and inability to move the right upper limb. So this is the radiograph showing fracture through the pathology site, expansile lytic lesion, medullary light. It's present in the medulla, so it's passing through that polyostotic fibrous dysplasia site. So it's a pathological, clear-cut pathological fracture. So what is the natural?
What's the natural history? Yes.
Yeah, what is the natural history of pathological fracture in fibrous dysplasia, and can we treat it conservatively? And if not, what are the methods of surgical management?
So Deepak, you are well read. I think have you read the literature on this? Fibrous dysplasia and path fracture. How it is different than the UBC and path fracture?
I think, sir, I've not read the literature on fibrous dysplasia exactly, but what I have experienced, I have seen others X-ray also. They have some non-union issues if the osteotomy or the fracture is through that fibrous lesion, as compared to ABC and other lesions, because they generally unite well. But in these cases, there can be a chances of non-union and pseudoarthrosis, development of pseudoarthrosis.
Right. Another thing is the lesion will remain persistent because it's not an UBC. In UBC, in 10 to 15% would heal.
Yeah.
And they get to repeat fractures, as Gaurav said. Bone graft doesn't work. That's right. But bone graft gets resolved. But our onco surgeons, sometimes our onco surgeons sometimes they put graft, and I've seen Bisphosphonate child is already on bisphosphonates. This is polyostotic. So endo team is already giving bisphosphonate. Now, Chinmay, how would you treat this? You plan to treat it with some surgery and reduce it. How would you do it? Or Vikas? Yeah. Anyone can take this. How would you like to fix it? A nail, plate, nails, and what nail? This is a young boy. What is the age, Goda? 7 years? 7.5 years, yeah. So,
sir, it is fixed with a stuffing nail like enders and give the cast for the long time.
Yeah, so enders would be your choice. You would be antegrade or retrograde?
So from distally, I will pass it. Okay. Just to get a more fixation.
So that's right. We chose titanium elastic nails. Yeah. Goda, what is literature?
Yeah, so we found a case, she was a case of polyostotic fibrous dysplasia, and she had recurrent fractures since the age of 12 years. And most of her fractures were treated conservatively. So this case report enlightened that primary management for polyostotic fibrous dysplasia fractures is preferentially intramedullary nailing because it acts like an internal splint, but conservative management has a role in certain cases. So we went ahead and did closed reduction and retrograde TENS nailing in this case. But the challenge that we faced was it was difficult to negotiate the second TENS nail through the medullary cavity. And hence we had to stop it midway, and but still we achieved good reduction and gave him a slat support.
See, the issue is the margin of lesion is very sclerotic.
Yeah.
And so when you reach to that margin, you might have to hammer your nail. And with, you use TENS, the tip is bit, it's curved and bit pointed. With enders, you may break the bone. I can tell you that. So whenever you are passing through the sclerotic margin of the lesion, you can have something to ream, and you should choose something, the insertion way where you can use a flexible reamer. Now we did not recognize that problem. So we just started retrograde to country with all, and we reached to the distal fracture site, both the nails. But after that, it was a difficult part to maneuver the nails through. I thought fellows would finish it off, but I had to get scrub, and even it was a problem for me also to maneuver it. But we had to hammer it cautiously so that we don't break the bone at other side, and we could maneuver one nail into the proximal part, and we stopped the second because the reduction was good. So yeah.
So the take-home message was reaming has a definite role before passing the TENS and such.
Yeah. So let's have a last case of today.
Sir, can we pass second nail from antegrade?
Yeah, you can pass antegrade also.
So that it has good functional length, and it may not go fully, but it can reach up to distal third. So that actually the strength as compared to second nail retrograde, if go for antegrade, then it has good jamming.
So if you pass antegrade, then you have to curve it in the other way to neutralize the lateral wire.
Yeah.
And the problem is not antegrade or retrograde. The problem is the cortical margin which we need to penetrate through. Yeah. Entry for medial. The Sujit is asking entry for medial TENS. So a bit of open incision, 1 or 2 centimeters, and go a bit anterior on the medial, medial pillar. With an you have to be very precise that your owl should not slip posteriorly or anteriorly. So the good way is to open for 2 centimeter, get it retracted, be on the bone, and under vision gently make your entry without getting it slipped. Yeah, let's go quickly through the last case.
We have a 4-year-old girl. She had a history of RTA. She was hit by a car 2 days back. On examination, the left lower limb was lying in the flexion, abduction, external rotation. There was tenderness over the left hip. There was no abdominal tenderness, or there was no blood in the urine. So these are the X-rays that we have. So I think I'm muted.
Chinmay, would you like to read this X-ray?
Yes, sir. On the right side, there is a fracture in intertrochanteric region, which is more of an undisplaced type. And on the lateral view, we can see the cortical line is well maintained. And
okay.
There is some in pubic fracture also, so in the AP.
Vertical chair of fractures. The acetabulum fracture is there, which can be made out with the SI joint disruption, with extending to the acetabulum posteriorly, as well as the superior migration of the superior pubic rami, as well as neck of femur fracture is there.
So I won't say it is extending to acetabulum. This is not extending to acetabulum, but this is a posterior ilium.
Yes, sir. Posterior ilium fracture with a
fracture and physeal separation. Yeah.
Yes. Yes.
So Vikas, how would you treat this?
So first, I'd like to fix the neck femur fracture.
Okay.
Then we'll give a traction.
How would you fix the neck femur fracture? This 3.5-year-old girl.
So it's pretty undisplaced, so we can go for screw fixation.
Screw, okay. Would you stop distal to physis, or you'll cross the physis? Distal to physis. Okay. Okay. What other way you can pass? Smooth wires also. And that smooth wires can be gently, it can be through the physis also. That will not lead to problem. Right. And how would you manage this physeal separation thing?
I think we have to fix that ilium so that we can manage that. There's a shear injury of symphysis pubis also. Is also disrupted.
So would you fix it?
Yes, we can try for traction.
Okay.
It is coming.
Any other view? How would you treat this pelvic injury, Raghavendra?
Sir, I need an inlet and outlet if it is available to see how far it is displaced. So because there is a large chunk of ilium bone which is involved posteriorly, so that definitely it's going to unite. That is not an issue. Only thing is that vertical chair, how far it is unstable. So I would like to just give a traction, sir. I would like to keep the child in a traction.
Yeah. So, and this is a kind of eversion injury, you know. So intraoperatively, with a bit of inversion and traction, this symphysis got partly reduced. So let me show you. Yeah, Meet, show the images.
So just quickly go through the 3 problems that we had. There was a neck of femur fracture, a symphyseal disruption, and an iliac posterior iliac wing fracture. So the option that we have for fixation of the neck were either with a spica alone, a percutaneous K wire, or a screw fixation. And for symphysis disruption, we could either conserve it or open and reduce it. And for iliac wing fracture, should we conserve or should we intervene? So this was the classification that is currently used is by Torode and Zig, and this was their paper published in JPO 1985, where they describe 4 types of injuries: avulsion injuries, isolated iliac wing fractures, stable injuries, and the type 4 is unstable pelvic injuries. So for the type 1 and type 2, conservative management is what they suggest. For type 3, if there's a superior pubic ramus fracture or a unilateral superior inferior pubic ramus or a symphysis pubic widening of less than 2 centimeters, like we have in this case, then we can conserve it. If it's more than 2 centimeters, or if the fracture is going through the SI joint, then operative management should be considered for this. Similarly, they also give a protocol for management of type 4 fractures, where this does not concern us in the current case, but this was what was the suggested protocol.
So, Meet, you can share this article on a fellows group. This seems to be an interesting article.
Yes, sir.
So we decided to show the immediate post fixation.
So we went ahead and we fixed the neck of femur with the 2K wire, percutaneously passed K wires, and we reduced the. We tried to gently maneuver the symphysis, and under traction, this is what we could achieve, and we applied a hip spica.
So I thought that this separation. Now we have seen a lot of bladder extrophy patients, and their symphysial widening, they tolerate quite a bit of widening. So I thought that this iliac wing will heal, and this amount of this separation, that will be tolerated well. I recently checked. Do we have clinical picture, Meet? Final clinical picture? So the patient came just a few days back. Yeah, this is the X-ray. And she doesn't have any limb length discrepancy, and there is a full range of motion. So we have started mobilizing this child now. And I hope we conserve this. Let's see if it makes any problem in future or not. We were conservative about this.
Sir, first go, if you put a pelvic bundle and go for the re-X-ray, does it change our line of management to treat these fractures?
Sorry, what was it?
Sir, on the first film X-ray pre-op, we can see the pubis fracture and iliac wing fracture, and if you put a pelvic binder and take another X-ray at the same time, do it change our line of management, or we still go for the or it is reduced or not?
See, the thing is that for neck femur fracture, you need to apply a spica anyways, right? Whether you fix it or not. So how would you put a binder when the spica is on? Or if you just put a binder, then you are not protecting the neck.
Just give an idea that it will get close or not. That's what I'm saying.
No, we tried. There was partially, it was reducible.
Yes,
but the question was to keep it reduced. It was a problem, we kept it in the maneuver and applied a spica, giving a bit of pressure from side. But we could not reduce it 100%. But this much of displacement, I thought that this will not produce problem. So we conserved. Now the time would tell us if someone has similar experience of this much of symphysial widening had given problem, then let us know. I have treated many bladder extrophy patients where our aim is not to align the symphysis 100%, but to that much so that this overlying skin can be closed. And those children, they don't have any problem, neither with length nor with a range of motion.
So what is your protocol for the removal of the wire, especially when it's fixed with KY?
I kept the wire buried underneath the skin. I don't keep it outside because then that with the movement the child does with the spica, there is a granuloma formation, is a rule always. So we cut it and we hammer it underneath the skin. And then once we remove the spica at 6 to 8 weeks, we remove the wires as well. And then we give a AKBK brace for some time. As is a young child, for older child, we give it for a pretty longer time. The young child, so 2 months is okay. I kind of always bury the wires because whenever I kept it outside, the granuloma and foul smelling and all those problems occur. Fine. So if I conclude today's session, we had this month was busy with some trauma. We We had a Montegia a day before yesterday, and a lot of trauma cases came, but each case had a unique message. And we understood that there is importance of getting a contralateral limb X-ray, especially in fractures around elbow. We also understood that whatever grave the injury looks like, an examination under anesthesia might make your life easier. So you need a good general anesthesia with nice relaxation, because once the child is completely relaxed, the treatment changes, the traction views would change your management. And always assess your deformities first with a CT scan, or if required MRI. It has happened many times that I have advised an MRI and then I ask family that it doesn't need any surgical treatment. So that is fine. But if you don't do an imaging and fix it half-heartedly, then it will lead to problems in future. And each trauma case is different. A simple looking fracture can lead to big problem, and a big looking problem gets managed simply. So they're very satisfactory patients. So thank you very much for your attention. I hope this session will help all of you in your clinical practice.
Thank you.
Take care.
Thank
Bye-bye.
you very much.
Yeah, bye-bye. Thanks, Deepak, for your inputs. Gaurav, Chinmay, Qaisur, and Vikas. Vikas was spot on for all the fractures. He's a great trauma guy, I would say.
Thank you, sir.
Take care. See you next this Saturday, day after tomorrow. We'll meet with a benign tumor by Mandeep. Mandeep is a great speaker and a huge experience, and his biopsy techniques, so that will be of great help to all of us. Yeah. Bye-bye.
Bye.